and various challenges which we are likely to face, and what strategies we can adopt to overcome those challenges. Now, why it is important is that competency based medical education is all about assessment. It's not about making a timetable, it's not about integration, it's not about anything else. In fact, we added a lot of unnecessary things to it to make it more complicated. But unfortunately, the major part, that is the assessment, actually got left out. So, two things are important for competency based education. One is a clear statement of competencies. And second, a very clear statement of how we are going to assess those competencies. We seem to be lacking in both. We neither have competency statements nor assessment. But anyway, competency statements is beyond us because we cannot change that. But surely assessment we can do. And if you look at the assessment pattern when you were a student, and maybe 5 years after that, and another 5 years after that, then you can actually notice a distinct change happening over a period of time. And most of the times, this change is not because of somebody's whims and fancies. You know, of course, now it happens like that. I decide to do it like this, so everybody start doing like that. But most of the times, the changes in assessment are a reflection of our understanding of clinical competence. So the way we view clinical competence, yeah, but so most of us are aware that 2019 we introduced this competency-based curricula, and the five rules that we set for the IMG, which included leader, clinician, professional, lifelong learner, and communicator. And I believe very recently they have also added two more, and that is critical thinker and researcher. So we are looking at seven roles, but if you look at the assessment recommendations, they focus only on clinician. I don't think there is anything to assess professionalism. I don't think anything for lifelong learning, even communicator. See, communication is highly specific. The way you talk to a mother to breastfeed her child is very different from communicating with a diabetic to change his lifestyle. Now, you cannot say, I know this, so I know that. So, both have to be done independently. And that remains a problem because we don't have that. Similarly, leadership and lifelong learner, so many things. Like I saw other day, there is an assessment of SDL. I don't know how we are going to assess SDL because there's no guideline provided, no information provided as to what exactly we mean by SDL and how we are going to assess SDL. But anyway, and this is what I said right in the beginning, that the effort in competency-based education should not lie in the design of instructional material, but it should lie in the design of appropriate assessment. View it like this, that 10 years ago or 15 years ago, very few colleges in India had OSCE. Very few. You could count on fingers, maybe 5, 10, whatever. But in spite of that, our students learned to give OSCE. And when they went for USMLE, many of them would come up in 99th percentile. So students would always adapt themselves to the needs of the situation. So basically, if you have an appropriate assessment, then you don't necessarily have to have all this jugglery of timetable, integration, foundation, electives, and so on and so on. They are all good teaching practices, but they are not specific for competency based teaching. So let's again come back to the same old question, what is assessment? So last time I had given you a definition, SEDARE, which means to sit with the student and do something with the student rather than doing something to the student. But if we want to really look at what assessment means, then it's a systematic collection, review, and use of information. Mind the three words: systematic collection, review, and use of information about educational programs to improve student learning. So, purpose of assessment is not to decide pass fail, is not to decide PG entrance, is not to decide scholarships, but simply to decide how to improve the learning of students. And that should be the major purpose. If you remember the diagram or the model that we had shown last time, the formative assessment actually formed a bigger chunk as contrasted to the summative assessment. And it should focus on what students know, what they are able to do, and what values they have. So again, we are talking of the three domains: what they know, knowledge, what they are able to do, skills, and what values, affective domain. And it is concerned with the collective impact on the student learning. So let's keep this in mind when we talk of assessment. And if we look at the pattern of assessment in last maybe 70 years, 80 years, then you can actually recognize three distinct phases. And these phases actually reflect our evolving understanding of assessment. Now, it's a different matter that we, for example, got stuck on phase one only, and we just continue with phase one without even thinking of moving to phase two or phase three. And another important thing, which you must keep in mind, that the psychometrics of, say, NEET cannot be applied to classroom assessments. Last year, 25 lakh students appeared for NEET. In your classroom, you have only 150 students. So statistically, you would know that the assumptions for 25 lakhs and 150 will never match. Similarly, look at the number of questions. NEET will have at least 200 questions. In a classroom, how many will you give? 10, 20, 15? At the most. Even in final exam, 20, not more than that. So to get a good and acceptable reliability and validity from 20 questions is just not possible. I mean, we somehow try to console ourselves. We are using MCQ, we are using this, we are doing that. But in effect, none of them is actually working when you look from a scientific point of view. And if you look at evolution of assessment, then these are the three phases you could recognize. The first was what was called measurement era. Second was decision making era, and third was the programmatic assessment. So we'll talk about each one of them, and let's begin with the first one, that is measurement era. Now, the basic assumption, and remember, this quote is from 1980, almost 106 years ago. And what Thorndike, he is a very well known in student assessment and psychometrics. What he wrote: anything that exists at all exists in some quantity, and anything that exists in some quantity is capable of being measured. Work in reverse. So what actually it means is that if you cannot measure something, it does not exist. So attributes like teamwork, professionalism, lifelong learning, you cannot measure them. So if you go by this philosophy, that they don't exist. And simultaneously came this McNamara fallacy. I hope you are aware of, right? Okay. During Vietnam War, this gentleman McNamara, he was a very bright person, and he was made the chief of Ford Motors in US. And from a loss-making entity, he brought up Ford Motors to a highly profitable enterprise. So during Vietnam War, they thought he is the right person to head the war operations. So he was made the chief of Vietnam War. And he applied the same formula that he had applied in the motor factory. And the formula was that number of dead and area occupied. These are the two things which we will consider as success or failure. So when we are fighting, we'll look at how many we killed and how much area we occupied. And based on these two parameters, he actually kept on telling US president and others, we are winning the war, we are winning the war, we are winning the war. But in effect, they were losing the war because they were not looking at other factors like the motivation of the locals, like the local geographic conditions, and so many other things. And from that time, McNamara fallacy became very important. And it is just an extension of what Thorndike said in 1918 that if you cannot measure something, then either it is not important or it does not exist. And if you look at educational assessment, in fact, it is highly influenced by these two factors. Everything that you assess should be measurable. If you cannot measure something, there is a problem. Simultaneously, if you look at the perception of competence, it was believed that competence is a trait, generic, transferable, and stable over time. I'll devote some time to explain these terms. Is a trait. That means जैसे आप गोरे पैदा होते हो तो ऐसे ही आप कॉम्पिटेंट पैदा होते हो या जैसे आप कोई बच्चा काला पैदा होता है तो वो ऐसे ही कोई बच्चा इनकॉम्पिटेंट पैदा होता है इस जेनरिक आप एक काम कर लेते हो आप सारे काम कर लोगे तो इट वाज जस्ट लाइक सेइंग कि अगर आप डोसा अच्छा बना लेते हो तो आप ढोकला भी अच्छा बना लोगे आप पूरी भी अच्छी बना लोगे आप पिज्जा भी अच्छा बना लोगे जेनरिक है आप अच्छे कुक हो तो आप सारा कुछ बना सकते हो ट्रांसफरेबल तो आपको अगर मोटरसाइकिल चलाना आता है तो आप एरोप्लेन भी चला लोगे चलाना ही है ना क्या फर्क है नो डिफरेंस एंड स्टेबल ओवर टाइम तो एक बार इम्तिहान ले लो अगर तो वो अगले 20-25 साल का गारंटी होगी कि देखो ये बच्चा कॉम्पिटेंट है बट वी नो कि ये तो बातें नहीं होती हैं ऐसे एंड देन कंटेंट context and situation plays no role. Some examples of concept I gave you. डोसा बनाना वर्सेस पिज्जा बनाना घर में बनाना वर्सेस रूरल एरिया में बनाना मेडिसिन की बात करें तो टर्शरी केयर हॉस्पिटल में कार्डियक लाइफ सपोर्ट देना वर्सेस प्राइमरी हेल्थ सेंटर में कार्डियक लाइफ सपोर्ट देना कॉन्टेक्स्ट प्लेज अ लार्ज पार्ट जो यहाँ पे कॉम्पिटेंट है वो वहां कॉम्पिटेंट नहीं होगा एंड वाइस वर्सा एंड पर्पस ऑफ असेसमेंट is to quantify learning and to separate competent from incompetent. हम असेसमेंट इसलिए करते हैं कि हम लोगों को दो में डिवाइड कर सकें कि ये कॉम्पिटेंट हैं और ये वाले इनकॉम्पिटेंट एंड इट्स इंटरेस्टिंग यू नो even when you do at item analysis today you look at discrimination index that means how well you are able to distinguish between competent and incompetent. And reliability has always been a concern. So if we look at reliability assumptions, it was very clear that to be reliable, it has to be objective. तो अगर वो ऑब्जेक्टिव नहीं है तो वो रिलायबल नहीं है. And secondly, reliability actually meant reproducibility. Even today, if you ask somebody who has done a basic course or even advanced course for that matter, what is reliability? What would you say? Same result under same condition. No, that's what we will see. Or reproducibility. वही हो गया ना. Basically, it is reproducible. मैंने 5 दिए, इनने 5 दिए, उसने 5 दिए, उसने 5 दिए, तो reproducible. पर ऐसे तो नहीं होता. And then, there is a lot of manipulation of numbers. I don't know how many of you are aware of the inside story of large scale competitive examinations. And I'm not singling out NEET. Any large scale examination will do that. What they will do, they will look at the result and they say, oh, question number 10 is lowering the reliability. So isko nikal do. So out of 200 questions that a student would answer, 20, 30, 40 questions would be taken off. And the result will be prepared only on the remaining questions. It's just like looking at a patient's chart who has died and then saying कि ये दवाई नहीं लगी होती तो बच जाता, तो ये कागज फाड़ दो, बाकी देख लेते हैं. It's something like that. And there was a very limited sample at last. 20 MCQ दे दिए, reliable हो ही जाएगा. So these assumptions actually gave rise to some of the very well known tools for assessment, multiple choice questions, objective structured clinical examination, oscillars, patient management problems, and so on. No, it's not that everything was bad about this. We still depend on MCQs. Although how we use MCQs now has undergone a lot of change. We no longer treat MCQs as something which cannot fail. A lot depends on what you ask rather than how you ask. So saying we are doing OSCE does not mean that you are doing a reliable assessment. What is in your OSCE is what makes all the difference. So there was unhappiness, and then we moved over to the second part, and that was the decision making era. जो major change इस era में आया, that was that from competence is generic and fixed, we actually started believing that competence is specific and non-transferable. So driving a car is not the same as flying an aeroplane, and flying an aeroplane is not the same as driving a motorbike. These are different things, and they need to be assessed differently. You cannot have one assessment for all types of driving licenses. That probably will not never work. And during this competence phase, this is the definition of clinical competence. There are plenty of them if you look in the literature, but this is Epstein and Hundred is one of the most respected and most cited definition of clinical competence. And again, look at the keywords. In fact, every word in this definition is a keyword. So habitual and judicious. And what does it mean? एक दिन दिखाने से कॉम्पिटेंट नहीं होती. You have to consistently show that you are performing that task well. So that is the first thing you remember, habitual and judicious. Second is use of knowledge, skills, attitudes, communication, clinical reasoning, values, emotions, and reflections. Again, in daily practice. for the benefit of the individual and community beings. अब यहाँ पे एक डिफरेंस नोट करने वाला है. You teach your student to pass a nasogastric tube on a mannequin. Does he become competent? Why? Because it doesn't benefit the individual and the community being served. So when does it become competent? When you bring him to the ward or casualty or emergency and make him pass an nasogastric tube. So that context becomes very important. So the behavior from independent generic trait, in those first era, there used to be what's called G factor. Sir will remember because during our time they used to talk of G factor. G factor is a general factor. He's generally intelligent. He's generally very good. But now we realize that there is nothing like a G factor. It's all specific and a combination of competencies rather than one factor which covers everything. And so what it implies it that we cannot have the concept of what we call one best tool. So if you ask me, what is the tool for knowledge with MCQ? No, that's not the best tool. That is one of the tools, but there are others. And I'm sure you must have seen this book on assessment toolbox, where we have actually listed out the different tools. And also remember that each tool has indications, side effects, and contraindications. And more importantly, you see the Miller's pyramid here. More importantly, none of the tool crosses the level of Miller's pyramid. So a tool which is assessing knows will not assess knows how. And what is assessing knows how will not goes to shoes. So what it means is that if you believe in Miller's pyramid, and if you have to assess the student according to Miller's pyramid, then you have to have a tool for each level of Miller's pyramid. You cannot have a generic tool and say, okay, we did MCQ, so certified competent. That doesn't happen. And during this period, just like in the earlier period, you had MCQs and OSCEs and so on. Now, during this phase, a whole lot of new assessment methods actually were developed. Mini CX, DOPS, PMAX, multi-source feedback, peer assessment tool, acute care assessment tool, handover tool. I just listed 7 or 8. If you look at the literature about, you can find about 40, 45 tools. For each specific thing, they have developed a tool. And the interesting part is that all these tools contrasted to the earlier tools are actually subjective. Mini CX is not objective. DOPS not objective. They involve a subjective judgment. And interestingly, they show a better reliability as compared to many of the objective tools. Like OSCE, highly objective, will give a reliability of 0.4 in 1 hour. Mini CX, which is very subjective compared to OSCE, will give you a reliability of 0.7. So most of these tools are subjective. And what actually came out is that the role of expert subjective judgment cannot be denied. View it like this. In fact, for clinicians, it is easy to understand. I'm sitting in my OPD, a patient walks in, I just look at him, make a diagnosis even without talking to him, and just 2 or 3 things to confirm or refute my diagnosis. Same way, an expert examiner can actually make a diagnosis of the student even in the initial 5 minutes. And then next time you devote, more time which you devote is actually to confirm or refute what you have already diagnosed. And then we come to the third phase of the programmatic assessment, which actually changed our behavior, belief that competence is dynamic. It can, on one day you may show a competence to a very high level. On some other day, because of some other reasons, you may not be able to do it. And it is contextual. I use that story of Krishna and Arjun. Arjun was highly competent, but he was not trained to fight his relatives. That was the context. So when the context changed, he said, I don't want to fight. Same way, in clinical medicine, there are a whole lot of things which are actually contextual. It's a little interesting. I went to AIMS for my training in uh, pediatric intensive care. And early morning for the rounds, the consultant asked the resident, have you done urinary ketones? It was a patient of diabetic ketoacidosis. He said, nahi sir, wo strip nahi hai. And it was accepted. I was thinking if this same thing had happened in my ward, I would have made this resident run, go to the lab, do a test with the local reagents available, Rothras, Garards, and then come back and tell. I mean, how can you manage diabetic ketoacidosis without knowing urinary ketones? Contextual. Because they are used to only doing it with strips. So if strip is not there, they cannot do anything. Now, what programmatic assessment believes is that education, competence, and assessment are complex entities. And a comprehensive assessment is possible only as a program of assessment rather than as individual assessment. Clinical reasoning, critical thinking, decision making. You can have diverse ways. Two clinicians may make two different diagnoses. Two clinicians may decide on two different methods of treatment. It's not that one is right and the other is wrong. Both can be right. And that is what you have to start accepting, that there is no one right answer. There can be more than one right answers. And that makes a whole lot of difference when you are teaching clinical medicine to the students. Now, during this phase, what happened? What changed? One, that assessment should be proportional to stakes. What it means? That for classroom assessment, maybe 2 tests might be enough. For end of semester, maybe 4, 5. Whereas for the final, you need to cover a whole lot of syllabi. Then summative decisions are not taken on a single test. So on one day the student couldn't do well does not mean that he cannot do well. Maybe he has another reason for not headache, family issues, tension, stress, anything can be there. So on one assessment, don't make a decision. There's a dissolution between formative and summative. Same assessment can be used as formative. Same collection of assessments can be used as summative. Like what we do for most of the non-medical cases in the university, like PhD program, for example. We will not decide your pass fail on one assessment. We'll collect 1, 2, 3, 4, 5, 6, 7 assessments, and that is right. Okay, you pass. When you have what do you call monthly tests for first hourly test, second hourly test. So what are they? They are just a collection of assessments to make summative decisions. You don't make a summative decision on only one. And you talk of the reliability of the program rather than of the tool. So I will not say MCQ is reliable. or OSCE is reliable. I'll say the assessment using MCQ, OSCE, and Viva is reliable. So the focus shifts from tool to assessment. Also, some more interesting things about competence, which you should know. One, that it does not reside in the individual. So it's wrong to label A competent, B not competent. Where does competence reside? It resides in the way an individual interacts with the context. And competence can be inferred only from performance. You don't have a meter, don't have a scanner. Let the student pass through it and say, oh, competent. That's not possible. So, what do we believe? That medical roles can be broken down into individual elements of knowledge, skill, attitudes, and you can rejoin them to create a competency. Those of you from medical background would know that. You had a so-called competency statement and you broke it down to objectives and these objectives and that objectives, and then you believe that in the end the student will be able to combine everything together. And we also believe that performance can be tested only like a race, precise, using a clock to 0.01 second. But after all, gymnastics is also a performance. And a lot of subjective assessment goes in assessing gymnastics. And it's accepted word. So why cannot we use an expert subjective judgment for clinical competence? Second is the dilemma between knowledge and performance. Recently they said, okay, 40% knowledge, 60% you can cover up either side, which actually is a wrong proposition. But some people would say if you use performance based assessment, it would promote learning of clinical skills. Because students know that in the exam they are going to be assessed on skills, so they would learn skills. That is one side of the argument. But the other side is that diagnostic reasoning, which is the first step of a doctor-patient encounter, where you will use a skill only after you make a diagnosis. If your diagnosis is wrong, then no amount of proficiency in skills actually helps you there. You have to make a correct diagnosis. And for that reason, the focus actually tends to shift from cognitive skills to behavior. But if you look at some of the published data, then what you find is that OSCE scores don't align with the diagnostic reasoning skills. Another thing which you see is pass rate on an MCQ test related to skill was only 39%. So what these people did, they assessed the students on skills and then gave MCQs related to those skills. So while everybody passed on the skill, on the knowledge part, only 39% passed. And then students would resort to selective learning. They would ignore knowledge rather than trying to learn both the things. Davies rightly said that experts are experts because they know more, not because they can do more. And if they can do more, that is also related to their knowing more. So we cannot ignore the role of knowledge. So what are the implications? That you need to give more emphasis to the cognitive elements. Basic sciences, it's happening. I'm not much worried about that. But once they come in preclinical, paraclinical years, that is where the problem starts. Your entire focus shifts onto the skills. So knows how, that is something which actually gets missed out. And very importantly, this sound diagnostic reasoning is something which needs to be taught to the students right from the beginning. We have seen Miller's pyramid, the base being knows how shows does a useful strategy. In fact, newspapers also do that. That's called inverting the pyramid. So rather than giving the whole story and then writing two key words from that, they would start with the keywords and then narrate the story because that generates more interest, because that generates more enthusiasm. So inverting the pyramid, especially for assessment of clinical competence, is a very useful strategy. Go other way around and then see what degree of knowledge they possess related to the skills that you are actually assessing. Okay. So any questions that you have or anything which I need to clarify more?
Then we assess, like, so उसके बाद भी does the first level will be does. So we need to check how he does or how we show them to do with particular competence.
See, instead of asking them to first write an essay on how to palpate the abdomen, you ask them to palpate the abdomen, and then you ask them, okay, what all you did, what all structures you came across, how did you palpate, and so on. Because you can't ignore the role of knowledge. Knowledge is important, and as I said, without a correct diagnosis, everything else is useless.
So first we perform and then we learn the facts related to that problem.
See the newer methods like problem-based learning or early clinical exposure, they work on these principles only. You first show them without teaching anything and then start teaching them on those parts. So not only it helps them to memorize things better, but it also helps them to understand the things better.
सर हमारा जो चॉइस बेस्ड क्रेडिट सिस्टम सिस्टम है सीबीसीएस सिस्टम तो क्या हम कोरिलेट कर सकते हैं कि इट इज प्रोग्रामेटिक असेसमेंट बिकॉज़ उसमें हम देखो फाइनल के ऊपर तो डिसीजन नहीं ले रहे ना वी आर गिविंग फर्स्ट आवर्ली सेकंड आवर्ली मिड टर्म एंड अटेंडेंस ऑल रिकॉर्ड एंड देन 50-50 हम ले रहे हैं 50% वेटेज वी आर गिविंग टू अर्लियर पार्ट तो कैन वी से इट इज सॉर्ट ऑफ प्रोग्रामेटिक असेसमेंट
प्रोग्रामेटिक में समेटिव होता ही नहीं है
होता ही नहीं ओके
The programmatic may you have a series of assessments and you combine all those together at the end to reach at a diagnosis. But having said that, you can have various shades of programmatic. So like 50-50 can also be there, provided you follow certain other things. For example, don't take decision on a single assessment. Use every assessment for feedback. Make decisions based on stakes. Higher the stakes, more data you need. Lower the stakes, lesser data you need. I think I'll give you an example from your own specialty. When you jump a traffic light and you are caught by a policeman, कोई proof नहीं चाहिए होता उसमें. He'll go to the magistrate and say, sir, इन्होंने तो light jump करी थी. He'll say 100 rupees, go. But if it is a case of homicide, then even a self-confession will not be accepted. It has to be proven beyond doubt that yes. So same thing happens here. For low stake assessments, small things, even objective, subjective, it's all right. But the more you keep on rising toward higher stakes, like for example, you cannot do these things into a NEET because stakes are very high. You cannot do these things in the final university examination. But at the same time, we could have done all this during the course of the year, but we don't do it there also. That is the whole point. Sir?
What is going to be, the way forward beyond programmatic assessment?
See, what I strongly believe is that by saying that formative assessment and internal assessment will not be counted towards the final, they have actually given you very good playing field. You can actually use it to the way you want the students to learn. Earlier, the problem was these marks were added to final. So, everybody was touchy about it. उसको एक number ज़्यादा दे दिया, मेरे को एक number कम दे दिया. Now it is not like that. All that you need is 50%. But you could use it to provide lot of feedback and lot of remediation to the students, because anyway it is not going to be counted.
But the point is how we are using it. We are using it to decide the eligibility criteria for appearing in the summit.
प्रोग्रामेटिक में भी तो एंड में तो आप वो समेटिव डिसीजन तो लेते ही हो ना, बट वो उससे पहले जो कुछ होता है हम उसमें यूज नहीं कर रहे हैं. So we still give them 4 tests, 5 tests, put up the marks on the notice board and finish. So that is where the utility actually ends. They have to use that assessment data, and like we discussed in the mentorship program, that can be the first point of discussion between the mentor and the mentee. So why low, why high, what can be done to improve or better your performance and so on. It will require.
Also, sir, जो remedials हम plan करते हैं, they should also be a part of the program throughout.
हाँ जी.
The remedials will be towards the end before the final eligibility decision की हम 2 test देके remedial करके.
See, Tanvir, the purpose of remedial is just like when you are treating a patient. Suppose a patient with anemia comes to you and you see hemoglobin 6 grams and you prescribe iron, you allow 2 months, 3 months for the medicines to act before you repeat. हम यहाँ क्या करते हैं स्टूडेंट के साथ में, अच्छा तेरा 6 नंबर है, चल कल तो दोबारा टेस्ट दे दे. यू नो दैट इज वेयर द प्रॉब्लम स्टार्ट्स. तो वो रेमेडिएशन नहीं होता है. It is only, bypassing the system to make sure that he gets 50% and moves forward.
So the point which I wanted to say was that remediation should be an important component of the program.
Exactly.
Proper spacing.
हाँ जी, हाँ जी, हाँ जी. We had actually proposed a model for programmatic assessment. I'll send you the paper so you can disseminate. And
the NMC in the curriculum, whatever they have laid down, competence-based medical education, have they considered this aspect for their medical assessment? Not so far.
It's left to the colleges to the remedials also in assessments.
So it can be the prerogative of the principal here.
See, they have
how to make the whole teaching learning effective.
Exactly. Not only principal, the faculty. Like what? नहीं सर नहीं, प्रिंसिपल से बात में फर्क आ जाता है थोड़ा. I'll give you my personal example. When I was in CMC, and there were whole lot of new things like OSCE, which people had not even heard in this country, and I'm talking of 1992, 93, 35 years ago. That time we introduced OSCE in our system. And the concern was the same. People will come and say, oh, you have put it, MCI will object, this will object, that will object. Our answer was simple. Have they said don't use OSCE? No, use it.
How I can then train my graduates? That should be the concern. Over and above, beyond NMC's directions, what improvements I can incorporate so that I can accept.
Moreover, so many things like how you teach, how you assess, they don't come and see those things. Fortunately, they look at only tables and chairs. They don't really look at the teaching learning process. So it gives you a freedom to innovate, freedom to add new things. So next week we'll have another topic. And then, thank you.
Please, please.
अब करेंगे वो भी करेंगे that also will.
And meeting in stop shares, and meeting in. Also, meeting.
Record.